The human hip joint is a complex load-bearing structure. It must combine wide-ranging mobility with enough stability to absorb forces that often amount to several times our body weight during simple daily movements. To maintain this balance, the joint relies on a protective musculoskeletal system of cartilage, intra-articular fluid, and the labrum. When this system fails, the destruction typically follows one of two strictly distinct kinetic pathways. The first is acute traumatic injury. This occurs during a sudden, high-energy event where the mechanical force spike exceeds the ultimate tensile strength of the human bone or surrounding soft tissues. The second is chronic overuse injury. This is a gradual process of mechanical attrition, where cumulative, repetitive loading outpaces the tissue's intrinsic capacity for repair. Because these two kinetic profiles result in different patterns of damage, securing an accurate prognosis requires matching the specific pathology to a precise multimodal imaging protocol. High-energy trauma, such as a hip dislocation, represents a massive structural failure. These injuries carry an immediate risk of avascular necrosis, the death of bone tissue in the femoral head, if the joint is not reduced within a critical 6-hour window. Conventional radiographs confirm a posterior dislocation, but X-rays cannot show the full extent of collateral damage. A post-reduction MRI is essential. This axial MRI reveals a displaced posterior acetabular rim fracture and a high-grade piriformis muscle tear, marked by extensive hematoma. In adolescent populations, the site of structural failure shifts. Before skeletal maturity, the cartilaginous physis, the growth plate, represents the biomechanical weak link in the chain. Sudden acceleration forces apply intense tension. Instead of the tendon tearing, the force pulls the apophysis away from the bone, resulting in an avulsion injury. To detect these specific failures, radiologists utilize fluid-sensitive STIR MRI sequences. On MRI, an acute avulsion presents as physical physeal separation with a bright fluid signal. We see the hamstring tendons displaced from their origin at the ischial tuberosity. The scan identifies bone marrow edema and hemorrhage leaking into the surrounding obturator internus muscle. High-energy trauma necessitates an evaluation that extends beyond simple osseous imaging. Post-acute MRI is the only way to accurately map the full radius of the internal damage. Acute injuries also arise from direct blunt trauma or forceful myotendinous contractions, frequently resulting in severe muscle strains. A significant complication of direct trauma is myositis ossificans, or MO. This is a reactive form of bone formation that occurs abnormally within the muscle tissue following an injury. In its early stages, MO presents a severe diagnostic challenge. It can appear as a soft tissue mass with massive perilesional edema, creating an imaging profile that mirrors an aggressive malignant tumor. To confirm the lesion is benign MO, radiologists look for a specific feather-like edema pattern spreading along the muscle fibers. The MRI shows a hyper-intense lesion with a dark rim, surrounded by this extensive edema. Recognizing that this edema pattern often exceeds twice the size of the central lesion prevents misdiagnosis and spares the patient from unnecessary invasive biopsies. Chronic overuse follows a different kinetic pathway. Here, repetitive mechanical microtrauma accumulates faster than the bone's intrinsic ability to remodel and repair. These stress injuries are typically invisible on initial radiographs. When a stress-related bone injury is suspected, clinicians must pivot immediately to fluid-sensitive MRI. Stress injuries follow a predictable 4-grade sequence on MRI. Grade 1 shows isolated marrow edema. Grade 2 adds T2 signal changes. Grade 3 demonstrates low T1 signal without a cortical break, and Grade 4 represents a visible fracture mine. This arthrogram of a runner shows how an established stress fracture presents after a period of increased mechanical loading. The indicators of failure are localized at the medial cortex. We can see bone marrow edema and periosteal edema surrounding a dark, visible fracture line. Detecting mechanical overload at the marrow edema stage allows for intervention before an irreversible cortical break occurs, significantly reducing recovery time. Femoroacetabular impingement, or FAI, describes a pathomechanical cycle where bony incongruities grind against soft tissue during end-range movements. The first pillar of this conflict is CAM morphology. An aspherical femoral head-neck junction creates shear stress as it enters the acetabulum, leading to cartilage delamination. While the cam deformity is visible on radiographs, an MR arthrogram better identifies the secondary stress reactions, such as the os acetabuli, a bone fragment formed by repetitive mechanical stress. The second pillar is pincer morphology. This is an acetabular overcoverage that compresses the labrum against the femoral neck, eventually crushing the tissue. Radiologists quantify this overcoverage using the lateral center edge angle. While a normal angle falls between 25 and 33 degrees, an angle of 40 degrees confirms severe acetabular overcoverage. Pincer conflict is also influenced by acetabular retroversion, where the entire socket is tilted backward, crowding the joint's anterior space. On a radiograph, retroversion is identified by the crossover sign, where the anterior wall projects lateral to the posterior wall. While these morphological traits are often found in asymptomatic individuals, in patients with pain, they provide the structural basis for progressive cartilage delamination. The critical third pillar of FAI is pathologic femoral torsion. This geometric factor determines the rotational limits of the femur and where mechanical contact occurs. Increased antitorsion can push the mechanical conflict outside the joint capsule entirely, causing the proximal femur to crush tissue against the ischium. This torsion angle is calculated using superimposed axial MRI sequences, showing an abnormally increased femoral antitorsion of 40 degrees. The consequence is ischiofemoral impingement. We see an antero-superior labral tear and bright edema trapped within the quadratus femoris muscle. Evaluating overuse injuries requires mapping the entire three-dimensional kinematic chain, as abnormal rotation can destroy soft tissues far outside the primary joint space. High-energy trauma and chronic mechanical overload both disrupt the joint's internal environment, frequently leading to secondary complications or the premature onset of joint disease. This MRI arthrogram shows the result of advanced degeneration, severe labral hypertrophy, and extensive cartilage delamination, where the joint surface is physically peeling away from the bone. Intercepting this failure cascade requires strict adherence to a multimodal imaging framework. Conventional radiographs must always be the first line of assessment to establish baseline anatomy, alignment, and center edge angles. CT remains the standard for mapping complex bone fragments and providing the three-dimensional data needed for preoperative planning. High-resolution MRI is the definitive modality for unmasking marrow edema, muscle tears, and early chondrolabral failure. By rigorously mapping the kinetic mechanisms of impact and attrition to their specific imaging signatures, clinicians can intercept the failure cascade and preserve the functional longevity of the hip joint.